is not, what's this? No?
Sorry, that's me, but I'm ready to go when you are, Madam Chair.
Very good. Oh, thank you. Good morning, everyone. My name is Liz Braden. I am the chair of the Boston City Council Committee on Strong Women, Families and Communities. I'm joined this morning by my colleague, Councillor Anissa Sabi-George, who is the lead sponsor of this hearing. This hearing is being recorded and broadcasted on Xfinity Channel 8, RCN Channel 82, FiOS Channel 964, as well as live streamed at boston.gov/citycouncil/TV. We will take public testimony at the end of the hearing. If you're interested in testifying, please email Ron, ron.cobb, C-O-B-B, at boston.gov for the link, and follow along on the live stream to know when it's your turn to speak. Please state your name and affiliation and residence, and limit your comments to a few minutes to ensure that all comments and concerns can be heard. With no further ado, I would like to introduce Councillor Anissa Sabi-George, who's the lead sponsor of this hearing. Docket number 0234, an order for a hearing to review the women-specific outreach and healthcare programming to combat the opioid crisis. Thank you, Councillor Sabi-George.
Thank you very much, Madam Chair. And while the opioid epidemic is currently impacting our entire city, we're seeing an alarming increase in the number of young women struggling with addiction and an increase in sexual violence. The traumas leading to addiction and experiences due to addiction or homelessness last a lifetime, but they also can be carried forward for generations. We need a public health response that makes healthcare and recovery programs widely available, with a particular focus on women dealing with opioid use disorder. We have a responsibility to these women, to their families, and future generations to stop the cycles of trauma, homelessness, and addiction. I'm eager to hear from our panelists about what's working on the ground and what policy or budgetary changes we need to make to expand those efforts. I know this won't be the last time we have this conversation, but I am grateful for all of you who are here today to help us improve the city's efforts to supporting women dealing with addiction, but also dealing with the traumas and the impacts of homelessness, substance use disorder, and inadequate and inappropriate access to mental health services. And as we see, I think what is an alarming increase in violence against women, especially women who are unsheltered and dealing with substance use disorder, very much concerned about the needs for us to improve and increase access to a variety of services. And the panelists and those that are here today to discuss some of that work, I'm grateful to them for their efforts day in and day out. It's a sort of a 24-hour-a-day effort that needs to be sort of managed, and I think we need to be looking at an increase in services and improvement of services to women in particular who are living unsheltered. And although we see a lot of that sort of play itself out at the intersection of Mass Ave and Melnia Cass Boulevard, it is certainly something that women are impacted by across our city and all of our neighborhoods. So we do have, Madam Chair, a panel here today that you have a list of, and I'm grateful for their presence.
Thank you, Councillor Sabi-George. So I'm looking at your panel list. I think number one would be Jen Tracy, Director of the Office of Recovery Services.
Good morning, Chair Braden, Councillor Sabi-George, and members of the committee. Thank you for the opportunity to provide testimony for today's hearing. My name is Jennifer Tracy. I'm the Director of the Mayor's Office of Recovery Services. The office strives to provide critical substance use and recovery services to the City of Boston and its residents. It is no surprise that the opioid epidemic has had a tremendous impact on our city, and we have been working tirelessly to ensure that Boston is at the forefront of prevention, intervention, harm reduction, treatment, and recovery efforts for people with substance use disorders and their families. Our focus is providing equitable and comprehensive recovery services by increasing access to care and filling critical gaps like we're discussing today. We work across all neighborhoods and support 3 campuses, one in Mattapan dedicated to residential treatment, and the Mascas area that focuses on street engagement, treatment access, and harm reduction services. Our street outreach team provides Narcan, directs people to care, provides recovery coaching and support. The Engagement Center offers a safe place for people to go off the street during the day for social interaction, bathrooms, and medical support from the Boston from the Healthcare for Homeless nursing staff. Our AHOPE program provides comprehensive drug user health and critically important work connecting people to care, HIV, STI testing, Narcan and overdose prevention, linkages to medical care, behavioral health, and social services. Prior to the pandemic, AHOPE provided women identifying drop-in hours every week on Tuesdays. Women could come and attend groups, get supplies, get off the street and be in a safe place with other women, have lunch, participate in activities, and access specific services such as from BARC, Intimate Partner Violence Team from BMC, self-defense class, on-site nurses for HIV medications, birth control, and STI support. This need was identified pre-COVID, and with our recent move back indoors after providing services outside for the past year, we will move to institute this programming again. Next door is our PATHS program, where people are placed in treatment with transportation 7 days a week. During the pandemic, the program sent almost 4,000 people to treatment, fighting for access at all points in the continuum. In Mattapan, we have 3 residential programs that support up to 100 men and women in early recovery, helping to stabilize them for the next step on their journey. 2 programs serving women include Entre Familia, a 12-month residential substance use treatment program that provides bilingual, bicultural, gender-specific substance use disorder treatment to pregnant and postpartum women and their children. All of our programming is evidence-based with proven success in providing culturally sensitive services to all women and their children, a population historically underserved in substance use treatment. During the pandemic, we admitted 43 women to this program and their children, providing essential support during this critical time. Lastly, Transitions, a short-term post-detox program that provides a safe place to stabilize and connect to the next level of care. 44.2% of the 525 admissions during COVID were female. Boston is a leader for substance use care, which is only possible through our strong partnerships with a network of community-based providers, hospitals, community health centers, shelters, and other stakeholders. But critical gaps remain, and within specific populations of people, namely women with substance use disorders. Some of the needs that are specific to this population are access to safe spaces that are women identified only, more sane, specific nurses so that women who do choose to go to the hospital after an incident of assault or rape will be met with quality and appropriate care, replication of best practices to increase access to medical care, similar to Project Respect at BMC, more training to providers and other sectors on how to talk about survival sex, building trusting relationships, engagement, the intersection with trafficking, substance use as a chronic disease, stigma and discrimination related to substance use, trauma-informed care, increased housing and treatment beds for women, reunification and family resources, along with resources for women who are pregnant and using, and support during postpartum and up to a year of support for women. Basic needs in safe spaces such as food, showers, and laundry. To address these gaps, the city has participated with the State Department of Public Health and various organizations to conduct a needs assessment specific to addressing the unique needs of women who are engaging with substance use. What we found and what we see daily is that women do not nearly have enough support, resources, or access to adequate and competent care. Women who engage with substances and who are unhoused have unique needs, often take part in survivor sex in order to meet some of their most basic needs. When engaging In this practice, women are then exposed to communicable diseases, sexual assault, violence, abuse, and are often stigmatized in the process. We are seeing a rise in HIV cases across the city, and that is also disproportionately affecting women who have a substance use disorder. Our office has spent the past year advocating for women and their needs, and our efforts have been successful. The Department of Public Health recently awarded $2 million for a new model of care focused on low-threshold housing for people experiencing homelessness that are at risk for HIV and who have a substance use disorder. This first-time effort also includes 2 outreach coordinators focused solely on reaching women. An incredible step for our unhoused female population, but there is still much work to be done. As organizations reopen and restrictions are gradually lifted, we will work together with the mayor and the council and our partners to meet the complex needs of women with substance use disorder. Thank you for the opportunity to provide input to this important conversation, and I will remain here, of course, to answer questions. Thank you.
Thank you, Jen. Very comprehensive and impressive. So next up is Stephanie Acker-Hausman.
Great. Good morning, Chairman Breeden and members of the council. I want to thank Councillor Sabi George for sponsoring this hearing order and all of you for bringing us together on this important topic. My name is Stephanie and I'm the Interim Director of Homeless Services at the Boston Public Health Commission, where we aim to make homelessness rare, brief, and one time. At our Woods Mullen Emergency Shelter, we serve any individual 18 years or older who identifies as a woman and who is experiencing a crisis of homelessness. We are often the absolute last stop for women. In 2020, we served close to 1,200 women at our Woods Mullen shelter, where they could utilize our facilities to have a safe place to sleep, shower, have warm meals, and access to our housing, behavioral health, and workforce development services. Close to a quarter of these guests were actually brand new to us, entering homelessness for the first time. The women we serve are strong, resilient, savvy, and never afraid to tell you how things actually are, so I'll try to follow suit in my remarks. I want to tell you about 2 of our guests, Frankie and Colleen. Frankie arrived at Woods Mullen Shelter struggling with her ongoing addiction to heroin and amphetamines. She recently had found out she was pregnant. Our staff were able to connect her with the local methadone clinic to curb her cravings. She also got connected to services at Rosie's Place and the on-site doctor from Healthcare for the Homeless who works out of our Woods Mullen clinic. She will tell you she's still struggling, but also that she has more hope than before and is working with our staff to quickly leave shelter to a permanent place. Colleen has been in and out of Woods Mullen many times. She is struggling with substance use disorder and her co-occurring mental health condition. She's been trying multiple times to get into detox programs and seeking out treatment beds, but has struggled to get placed due to COVID testing requirements and her mental health challenges. While she eventually has made it to detox on several accounts, she's always discharged back to shelter, to an environment where she is struggling, where many are struggling just like she is. Frankie and Colleen give us a small window into the utter tragedy of when trauma, homelessness, mental illness, and substance use disorder all collide. 80% of our guests have at least one disabling condition, 40% are survivors of domestic violence, and 60% have a mental health diagnosis. These confounding factors mean that for many of our women guests, the crisis of homelessness is not a short-term crisis, but a long-term pervasive reality. And while those numbers are bleak and the need for services and change are vast, I'll highlight some of the ways that we're addressing this reality, often in partnership with many of the other incredible organizations represented on this panel. So we welcome guests into our shelters with no preconditions, which means guests can enter into our shelter under any state. We're endlessly grateful for the city's commitment to improving our physical shelter and want to thank Mayor Janey for her support. Part of the many things that the city's campus renovations project at our Woods Mullen Shelter include a state-of-the-art medical clinic in partnership with Boston Healthcare for the Homeless, and will include a dedicated supportive place for observation and treatment once it's completed. We served as an incubator with the local electrician, John King, in 2019 to develop a multi-stall bathroom monitoring system. This allows us to ensure that guests are safely monitored from potential overdoses. We meet guests right where they are and work to get them housed and employed with no preconditions. Housing First is a harm reduction approach to ending one's homelessness. We have increased our housing services by 200% over the past 3 years, specifically increasing the staff dedicated to helping our guests at Woods Mullen navigate an array of complex barriers to accessing housing. We've created partnerships across the city by employing peer navigators who have lived experience to better coordinate and serve women who access all of our services. Our workforce development program hires clients like Frankie and Colleen as Health Commission employees to perform custodial and culinary services, giving people income, work experience, and continuing to demonstrate that supportive employment helps people in recovery. And we're continuing to improve. We've improved our training and our policies to better serve and welcome transgender guests and better respond to the trauma that all of our guests have experienced. We've continued to expand our language access with a majority of multilingual staff, a language access line, and written materials and signage in languages other than English. We've seen some promising signs with ambulance calls for overdoses declining, and the opening of new sites across the city in response to COVID has allowed us to keep our census lower and provide higher quality services. Later this month, in partnership with Friends of Boston's Homeless, we'll be opening a new redesigned floor at Woods Mullen Shelter to support guests who are working on recovery. In closing, I want to thank the Committee on Strong Women, Families, and Communities for allowing me this opportunity to testify. While we're proud of the work we do, the needs are endless and urgent, and we look forward to working with this committee and all of our partners here to better understand the drug epidemic among women. I'm happy to answer any questions from the committee. Thank you so much.
Thank you, Stephanie. So we will go on to Pam Gonzalez.
Morning.
Good morning, Pam. Are you able to? Are we able to see you, or are you
I'm
just
looking
going to?
for me. I'm sorry.
Not to worry. We can hear you loud and clear. So go ahead.
Okay. Well, good morning, everyone, and thank you for having myself here to.
Pam, I think you need to unmute yourself. There you go.
Here I go. Well,
Good.
again, good morning, everyone. Sorry for the inconvenience. I am here to represent Project Place. Also want to say thank you to the City Council, to the other speakers, to everyone else that was here to hear what we're talking about. Project Place, we work with the women. I coordinate a women's program called Working Opportunities for Women. And what we do is we get women from all the different trauma that are existing, women that are coming in from the homeless shelters, women coming out of recovery, women re-entering the community. We have women that are been trafficked, working with them. Our main purpose is to have them to get secure, get reunified with their families, and provide some job training so they can feel and become self-sufficient, build some confidence within themselves and some self-esteem, which is an important part of the recovery. We provide time, assistance classes, which is work ready, where they attend for a month, where they can work on time management, learning how to incorporate their time with different organizations, how to present themselves, and how to go on interviews. We also have Spark, which is a program where we are working with women that have been traumatized, that need a little bit more before they're ready to go to work, with some assistance around their mental health. This can also go for another month, or when this person feels, or we feel that they're ready to move into the next aspect of what they're doing. I work along with CREW. CREW is the program where women that are coming out of the house of correction, they come to us and they are provided with services through CREW and working very closely with them around providing jobs, leadership, working with other people, understanding what's going on in their life, providing recovery treatment, sending other resources out to them, and especially giving them a second chance at life to recover themselves. Some of the women we work with have never had a job. Some of the women have been in situations of coming off the streets from recovery, coming into us from being trafficked, building trust, building a place to feel comfortable and able to talk very openly about what's going on with them. And we work really hard to provide this. I don't have our exact numbers, but due to this pandemic, we do everything very virtual. We do have appointments where they can come into the office and meet with us, or we'll meet with them where they are. I've been here for 6 years. I provided and worked with many, many women. And I know the needs of a lot of these women are not being given or met. We need the services, and we're asking that we can provide a little bit more. Project Place works really hard to make sure that the women that are coming to us know that the resources are out here, and always looking for new resources, because the resources are not always available. They're not always able, and people do not always respond back to us. I have my coworker here with me that I'm hoping that she can give another insight into what's going on with us. And again, thank you for having us.
Thank you, Pam. Is your coworker Larissa?
Yes.
Okay, Larissa is on the list for next up. So Larissa, we'd love to hear from you. Oh, and by the way, we've just been joined by Councillor Ed Flynn. Thank you.
Hello, everyone. My name is Larissa. Again, thank you for allowing us to be here. So like Pam said, Project Place is a supportive community that promotes hope, opportunity for homeless and low-income individuals. We provide skills, education, and resources needed. I am part of the reentry department. I'm also the crew instructor. So in the reentry department, we provide a path to success and financial independence for individuals returning to the community after incarceration. Using an integrated team approach, barriers are identified and addressed through wraparound services that address specific needs of reentry. Participants gain guidance of navigating the work world with the quarry, and Project Place develops industry-specific skills with quarry-friendly employers. Work opportunities are focused on local growth industries to set a path for positive career trajectory, and we do all sorts of things like provide assistance with probation and parole and a release. We'll give you a ride home. We do the crew programming prior to the release, which I'll talk about in a minute, but we do discharge planning, providing transport, like I said earlier, continuing of care for medical and mental health, substance abuse treatment, including making those appointments with them, seeing them through, trying to help them seek that shelter and housing support, assistance with obtaining their birth certificate and their mass IDs and those social securities and things like that that are important for them to sustain. But the crew class itself provides like hard and soft skills that assist in daily life, like decision making, understanding your individual characteristics, your interpersonal competence, and relationships. It's working through disagreements, parenting skills, like emotional management, and in job readiness skills, it's like resumes, interviews, and vocational interests. The case management and discharge planning is provided alongside House of Corrections case managers, which is awesome because it allows us, even through COVID with the pandemic, when we weren't allowed inside, we were still kind of allowed to collaborate and work with them. But once graduated and named a crew alum, we provide case management services for as long as you are willing and able. I know we're going to talk a little bit more later about like what we decide as needs, but just quickly, I think one thing that Project Place strives with is like communication and care coordination, being a team and having a team involved, kind of recognizing that people have more than just their addiction, and that we need to recognize that their family supports could be useful to them, and kind of getting to know them beyond just their addiction really helps facilitate change and sustain that change in their life. But yeah, again, thank you for being here. Thank you for allowing us to be here. And I look forward to answering any questions and hearing from other people.
Thank you. Thank you, Larissa. I'm just checking in with Ron. Do we have anyone from Boston Medical Center in the waiting room?
Madam Chair, Councillor Mejia is in the wait room, as well as the two doctors from BMC.
Okay, can we let some more people into the party here? Ron? Thank you. Ron, sorry. So we've been joined by Councillor Mejia and Dr. Iveen Costello, and is the time right? And Dr. Kelly Shia. Sorry, I'm Saya. Is that correct? So moving right along, if Dr. Iveen Costello is ready, are you ready to testify?
Thank you. It's my honor to be here. Delighted. And you're the only person who's ever pronounced my last name the same as my grandmother.
Yeah, you're a Costello. You're one of the Irish Costellos, so I know how to pronounce your name.
That's exactly right. So I'm going to just share just a few slides if I can do that. I'm not sure that works, and I don't want to take up too much of your time. So
take your time.
Give it one more shot. And
We can see it. It looks like you just need to start presentation, so it's full screen.
Okay. Let's see here. Let's try that. Is that going to work?
Yep.
Yeah, that's good enough, I think. So my name is Iveen Costello. I'm a pediatrician at Boston Medical Center, and I have worked in the city of Boston my entire sort of pediatric career at 2 of the community health centers, and then 6 years ago I came back to Boston Medical Center as the chief of ambulatory pediatrics. 4 years ago, I started a program here called So Far, supporting our families through addiction and recovery. Really, the idea being to take care of the infants and children that were born through Project Respect, which you're going to hear about in a minute from Dr. Saya, who's an OBGYN, who runs a program for pregnant women with substance use disorders. And my program accepts the children of these moms, and we take care of them sort of as a patient-centered medical home, primary care medical home. The idea being that we all know that we're more likely to take care of our children than we are to take care of ourselves. Mothers are much more likely to bring their children for appointments than they are to come in and take care of themselves. And we try to capture the moms while they're here and then work very hard to connect them to their own postpartum care, mental health care, addiction care, community services, parenting supports. You name it, that's a big part of what we do. So I just wanted to talk a little bit about, these are just a few slides from a recent grand rounds. The impact of the past year on our patient population has been really enormous. And I think it's well documented that people with substance use disorders have suffered disproportionately because of their isolation. And we have seen dramatically more relapses, even deaths of mothers in our care since COVID. Many more removals by DCF because things have not gone very well for our mothers. In our cohort, the vast majority of the women we take care of, we have seen so far, this program started 4 years ago, about 350 mother-infant pairs. And we still have, right now, our cohort has about 250 kids in it. And I'm actually seeing 3 new babies this afternoon that are products of the Respect program, infants born to mothers with opioid use disorder. We follow kids from, birth until, however, up to 17. Our oldest kids are 17. And those are kids who are siblings of the infants and have come back from foster care or have come to us through other methods. I'm going to move on from this slide. It's because I think that for the purposes of this group, I think the most important message that I feel like I can get across is one cannot overstate how vulnerable women of reproductive age are, women with small children in this community of substance use disorders. We know that, Dr. Sai will talk about this, but the vast majority of women that we see here are in the very early stages of their recovery. They get into recovery because they're pregnant. And these pregnancies are almost always unplanned pregnancies. And as a mother said to me, well, everyone knows if you're in my situation and you're pregnant, you go to BMC. And so they typically will present to the emergency room saying, I'm a heroin addict and I am pregnant. And they'll come in and then Kelly's group will take over and provide very high level of care. So by the time I meet them, they're still quite early in their recovery. And now they have a really irritable and nudgy newborn. So even babies who don't suffer from severe withdrawal, these are dysregulated babies that are difficult to care for, hard to feed, hard to soothe, hard to get them to sleep, which just increases the stress on our mothers. this slide just shows what the risk of overdoses and how effective treatment is. So you can see there's a dramatic difference between treated versus untreated women. So the treated bars are the orange ones, the gray ones are untreated. So women who are on medication-assisted treatment, or MOUD as we call it now, are much less likely to have a severe overdose, but the risk goes up, and particularly in the second half of the first year postpartum. And that's exactly what we see. So one of my most important messages to this group is we're lucky in many ways in Boston compared to my colleagues across the country that we do have some recovery supports for women in the postpartum period, but they don't last long enough. So we've had so many stories of women, quote unquote, graduating from their recovery programs and then, going to scatter sites where they're very isolated in little apartments by themselves with small children. And that's when we see the relapses, in this 6 to 12 month period. The mom who overdosed at the YMCA 2 weeks ago and was found, deceased with a needle in her arm and a 5-month-old infant beside her, presumed to be dead for 48 hours by the time she was discovered, was a classic example of a woman who had been in a recovery program with a lot of supports and then, moved into a room at the YMCA, which is not adequate, for anybody with a baby, especially a fussy, irritable baby. I just wanted to share a little bit about the demographics of our group. We have worked really hard, Dr. Sai's group in particular has worked really hard to make sure that we're reaching communities of color as well as the white community, which have been traditionally overrepresented among substance use disorder treatment. And so it is changing. Like, this slide looks really different than it did 2 years ago. And we are bringing more women of color and more Latinx women into our community for treatment. The characteristics of the women we take care of, I think, is just worth mentioning that we see a lot of relapse. So in our group, this is after the first 2 years, 40% of our women relapsed after being enrolled in our program. So it's not unexpected. It's almost expected. Like, a good proportion of people are going to relapse, and our job is to keep them safe and to keep their children safe and to do as much as we possibly can to promote their sustained recovery. We now have 4 maternal deaths because that's a new one. Because I'm a pediatrician, I'm going to say this, and this will be the last thing I say. One of the things that I'm profoundly interested in is prevention of the next generation. And so we know, because we're a public hospital, the vast majority of the mothers in our program grew up in substance abuse families. Many of them have had tremendous losses. Their parents are dead of overdose. Their mother died of cirrhosis from hepatitis C. I have a young mother, 23, her identical twin sister died of an overdose. I learn about this by asking people about their tattoos, because their tattoos are almost always names of people they have lost. And so for many of them, their mental health disorders preceded their substance use, and they were not adequately treated for their ADHD, their depression, their anxiety disorder, and that's what made them pick up, because they've lived very hard lives. So now we have a cohort of kids that we really want to try to prevent. We want to make sure we're addressing their mental health disorders, their difficulties, so that they have other ways of managing their distress than picking up. In our group of kids, you can see that the vast majority of the kids have a mental health diagnosis if they're over 6 years old. Well over half of them have an IEP in the public school system. We field a lot of calls from educators in Boston about how to manage this population of kids. So I think the average is 1 in 5 kids are on an IEP, but more than half of our kids are on IEPs. And then I just think that my final slide is just going to be like, the future directions for us is, how do we support these women for longer than a few months after they have a new baby? We work really hard to make sure that contraception is available to everybody, to reduce, to prolong the interpregnancy interval, because we know that is, 2 babies too close together is the kiss of death for recovery. But we are very interested in dyadic care and in care that lasts longer. I mean, I have a fantasy that the moms and the kids could go to foster care together so they're not separated, which is an adverse childhood experience for the child associated with all sorts of negative outcomes later in life. Or some kind of community like a kibbutz, where we can sort of take care of people in a community and children can stay with their mothers who love them as much as any other mother. I'm happy to take questions. I would really like you to hear from my colleague.
Councilor Braden, I think, yes, that Dr. Costello is done.
Oh, thank you. Thank you. Thank you, Dr. Costello. This is a very comprehensive presentation. And I call on your colleague, my list here, Dr. Kelly Saya.
No, thank you.
Saya, thank you.
You also are one of the only humans on earth who has pronounced my name correctly.
It's with trepidation that I tend to pronounce unfamiliar names sometimes. I don't want to be offensive sometimes.
No, I'm very impressed. So thank you all for your time, and thank you, Eileen, for the introduction to our work. And I think Eileen, I think you're still sharing.
Oh, I'm sorry. Okay, let's see if I can figure out how to stop that. There we go. Thank you. Sorry.
Sure. Not that I have any slides that I'm going to present right now, but I just want to talk with you a little bit from the heart of our team. Boston Medical Center Project Respect has been sort of officially caring for pregnant women with substance use disorders for decades. I think since 2000, we've cared for almost 6,000 pregnancies. And we have a lot of experience. We have a lot of great outcomes and huge successes. But, you know, every day is a struggle, and we see it as new opportunities every day for our moms. Like Dr. Costello was talking about, it's phenomenal that we have the SOFAR team that is our sister group, because my entire team, our job is to engage pregnant women in recovery care, which the pregnancy sort of has that inherent motivator. So I don't have to do a lot of work about getting women in. We have to keep them in care during the pregnancy, and that is an incredible amount of work. I think that if we took a look at the number of touch points for one patient in our program through their prenatal care and up till delivery, the number of visits and interactions they have with our team equals the equivalent of about 4.5 to 6 years of primary care visits. And all of that is under an incredibly stressful timeline of urgency to get women stabilized, connected with all of their services, knowing that the gestational time clock is always ticking. And even with all of that work, we know that the pregnancy is the easy part. Mm-hmm. And that the incredible challenge is to hold these moms' hands as they enter early recovery and parenting. And we are, like Dr. Costello said, or Costello, years I've been mispronouncing that, said, we are so lucky in the Boston area to have the resources that we do. And we work very closely with multiple of the residential treatment facilities in the greater Boston area. But just like we are taking our prenatal care and extending it past that traditional 6 weeks postpartum into the full year postpartum, because that's really the challenges for these moms to stay in recovery, stay focused on themselves, their health, and parenting, and not letting all of those prenatal care, maternal supports drop away. That's one of the biggest risks that you see. And Davida Schiff's group and her research showing the huge spike in maternal overdose mortality that happens in that first year postpartum, and actually has a significant spike around 7 months to a year, which is right in that void of where moms are trying to figure themselves out and figure out their parenting and have yet to sort of establish their own primary care. So the general take on this, I think, is that we know that addiction is a chronic disease, and yet we still are using our resources to treat it as if it were an acute process. And so what we would like to build and to see is an element of sustainability for these families. And our residential treatment programs are fantastic in pushing those time limits of when they can stay. But what we need is something after that, the step-down programs, of which there are significantly fewer in the Commonwealth than the acute residential treatment facilities. We would like to see sort of those expanded, and maybe taking a new approach on it to have a center that is sustainable for women to always have as a medical home, something that is a conglomerate between all of the different groups in the city that are working on this, to create sort of a recovery center where these moms can, as their needs change, as their stressors change, but their addiction still persists, that they can continue to come and reach for care with us. So again, I think all of this, having these discussions, having our legislators and the different departments in the state work with the medical facilities is really the key to having these families survive and thrive. So thank you so much for your time. I really appreciate it.
Thank you. Thank you. Thank you for your work. Incredible. Councillor Sabi George, you are the lead sponsor. Would you like to lead off? Did I mention that Councillor Julia Mejia has joined us? So we have Councillor Flynn and Councillor Mejia here.
And I believe Councillor Flaherty has also been in the waiting room for 20 minutes.
Oh dear.
He's actually no longer, he's
Okay.
not in the waiting room. Councillor Flaherty, if you're watching, maybe you could come on back over.
Yeah, he
I
sent.
can't see the waiting room. I have no idea who's in the waiting room.
Yeah, he sent a text out. Yeah.
Councillor Sabi George.
Thank you very much, Madam Chair, and thank you to all of the presenters this morning, Jen, Stephanie, Pam, Larissa, Eileen, and Kelly. Just very thoughtful presentations. And Dr. Costello, is that the appropriate pronunciation?
Yeah.
Thank you. If you would share that presentation, I know that you highlighted a number of those slides, but it looked like a pretty thorough and presentation. So I'd love to take a look at it.
Rachel right now.
Excellent. Thank you so much for that. And we'll share it with colleagues who would like to take a look at it. So I'm going to just go back sort of to the top. And Jen Tracy, thank you very much for joining us and for your continued work. And we know the impact that COVID has had on our unsheltered population and those dealing with substance use disorder during COVID and certainly long before that. So I'm grateful for your service. Something, we've been working on this, preparing for this hearing and working on this issue for a long time now through some informal and more formal channels, but not through the public hearing process. So happy to sort of bring this to the public space. And one of the things that's come up a number of times over the last year in particular, or maybe a year and a half, has been the need for a 24-hour mobile van that provides a safe, warm place, but really a place for women to get services and some medical care. But the 24-hour element is particularly important, especially for women who may have experienced some sexual violence or other traumas. And I think about this is a real opportunity for us to provide additional care to women in particular, but women who are going on dates and need to, unfortunately, participate in the sex trade and are trafficked. Can you talk a little bit about any opportunities there might be for increased services, especially overnight services?
Yeah, thank you for that. That's our overnight system of care. Outside of the shelter system, there's a lot of, I think, gaps for us in the city of Boston. So we have been looking at how do we provide some access overnight. In last year's budget, as you know, we received some funding to research other cities around low threshold space in general. We've just completed a practice guidance around best practices for low threshold. And when we say low threshold, we mean really reducing the barriers to access to create safe spaces. So that didn't take a look at mobile units, but it did take a look at sort of how do we provide an additional piece to our overnight continuum in the city of Boston to provide supports to get people, particularly women, a safe place to go overnight, as you just stated. We also, right before COVID, and as you did as well, Councillor Sabi George, traveled to Canada to look at some of the mobile services that they were doing to provide care to women that were in, different pockets of the city. And so I think you're correct. This is an opportunity right now. We have federal support, from the administration. We have our state Department of Public Health receiving, additional support, and we're preparing for the opioid litigation settlements across Massachusetts as those resources, come to bear. So I think this is the time to really think about what the best model for Boston would be. Where would it be? Would it be mobile? And we're happy to, join in that conversation with you to continue kind of the conversations that we've been having, thus far. I just want to say one other thing. We also, are working closely with our shelters to see, particularly Stephanie and her team, to see what else, how else could we think about providing some low threshold space in our spaces that are open already 24 hours a day to give people that safety.
Yeah, no, I appreciate that, and thank you. One of the reasons I think the mobile care opportunity is one that's beneficial is we do see, especially with our homeless that identify as women, that they are a little bit more transient. And not always in sort of the immediate Mass and Cass area that sort of is a group of individuals who are mobile, and being able to respond to sort of where they are is very important to me, especially in those overnight hours. When we think about what might be happening in downtown, what might be happening in Nubian Square, what might be happening into Dorchester and South Boston or into the South End, that the mobility of that care, especially something that's available 24 hours, is really important to me. But it also leads me to, and if just to include Stephanie in this conversation, one of the other challenges we've heard from a number of women is, with the ever-changing drugs on the street and use patterns changing, that women, if they are entering the shelter system, in order to use, because they're dealing with an addiction and substance use disorder, they do have to leave the shelters in the middle of the night, sometimes to use again. And then they're barred from the shelter, and that creates some other challenges. But also, AHOPE gives out clean needles, but then they can't bring in the clean needles into the shelter, which those are affiliated agencies and efforts. And then when they're coming out in the middle of the night, they're then maybe using discarded needles. And we talk about the rise in infection rates, especially around HIV. There's this sort of loop, and our own policies are getting in the way of supporting our, some of our most vulnerable residents. So I don't know, Stephanie, if you can talk a little bit about that. And I do know, and then I'll save further conversation and question for the next round, Madam Chair. I do know Dr. Costello has to leave, so I'd like to have her, just if she's got more to add after Stephanie can respond to that concern.
Yeah, thank you so much. We are working really closely right now with recovery and have had many of our own meetings to work to address this. We recognize that there's a concern there, and so we're working on piloting a number of things. I want to say one of the reasons or kind of benefits of opening these other sites and reducing our shelter census is that it does create some better flexibility. So before, people, when they did leave for the night, some of it was because we didn't know if they were going to come back. And if we have someone waiting for a bed, we wanted to give them that bed and not have someone sitting in a chair all night. But that isn't as a concern as much. We have, as we've spread people out, we have some better flexibility to start piloting that. And we are working with partners. I had a meeting last night with Healthcare for the Homeless. We've been working with lots of different partners to try to do exactly what Jen said of how do we work to improve some of our policies and procedures to be more low threshold. So we've been talking to other shelters across the country who have amnesty lockers, working on what the logistics of that are so people do not have to choose between giving up their kind of items that make them safe and that they need to come into shelter while also still trying to keep our shelters as safe places for people who aren't using and for staff. So there's some definite constraints there, managing safety and meeting people where they're at, that we're working really hard on doing, and look forward to partnering to improve that. Also working on clean needle distribution. So we don't want people to, we can't have them in the shelter, and we don't want people to have to sneak them in, but we don't want to have to take away things that they just got next door. We 100% agree with that, and know there's a lot of work to be done and are excited to do it.
Thank you, Stephanie. I don't know if Larissa has anything to add. I do want to note, Councilor Braden, that Dr. Costello does have to leave. So if she has anything to add to either one of those questions before she logs off.
I think the mobile question is a really interesting one. And actually, in our department, a year ago, we instituted a mobile vaccine van at the beginning of the COVID pandemic because so few people were bringing their kids, literally in the course from Friday to Monday, our in-person visits in our primary care clinic, where we have 14,000 kids, went down to 10% of our usual volume. So we instituted a sort of mobile primary care van to keep the kids vaccinated. And now we actually use it quite a lot for so far because a lot of our moms really struggle with keeping appointments, with transportation, executive function. Suddenly they can't come because DCF is coming to visit them, and Lord God forbid they miss that meeting. And so we go to them, and we will bring vaccines and sort of primary care for the child. We are not doing this in the middle of the night yet, but I do know that some of the stories, and Kelly probably hears more of them than I do, are really harrowing about what's going on with some of our moms on the street overnight. Lots and lots of sexual violence and intimate partner violence, lots of traumas, and they do need a safe place to go. And right now, the only place for them to go is the emergency department.
Yeah.
Thank you. Thank you, Dr. Costello. Thank you, Councilor Breeden. I'll ask questions after colleagues. Thank you.
Very good. Dr. Costello, before you leave us, I had a question about the step-down programs. It seems like there's sort of a threshold that wants to go through. If there's acute residential treatment programs, then when they go to the step-down, there's fewer of those. It seems like that's a place where people fall off the cliff a little. How many step-down programs do we have, and what sort of capacity do they have, and what do you think we might need?
Well, Kelly, I don't know the numbers. I don't know if you do. Yeah.
Yeah, I mean, we have 18 family residential programs across the state that we can access. In our area, we have 2 step-down programs. They're quite good, 2 or 3, I'm sorry, that will accept women and children. So that's a huge area of need. And we can't facilitate the admission into those beds unless women have 6 months of recovery. And if they're not acutely requiring medical treatment or stabilization, they can't access the acute residential treatment, right? So there's also these windows. I know we need requirements for admission, but there's also windows of time where women can't access that. Like if they're 4 months postpartum, but they've been doing well, they still can't quite get into those step-down programs. So having, I think, more availability for those step-down programs, more homes to do that, and then also expanding those homes to have services not just for the women and children that are in the home, but those who have graduated would be amazing.
Yeah.
In some support, I just wanted to say one last thing before I need to go on at 11, but is some support for extended families, because I think the moms that, at least in my experience, the moms that seem to do better are the ones that actually do have the support of their extended families. And because, this illness makes people, do things that they wouldn't ordinarily do, a lot of them burn bridges with people that they love by, stealing or other things. And so a lot of them are really on their own. And a lot of families just don't feel like they have the bandwidth and the skill to take care of their child with a substance use disorder and a small child or an infant. And I think, I have lots of grandparents raising their grandchildren, and I feel like that is a group that really needs a lot more support and how to manage, it's extremely complicated emotionally, and it's expensive, it's time consuming, and it's not what they were expecting to do in their 60s and 70s.
Yeah.
I also wonder if I could grab a quick second to talk about the availability of Project Promise and the intensive outpatient programs for women, parenting and pregnant women in recovery. We had one Project Promise filled sort of this amazing, it was an amazing program out of the Spark Center that provided ongoing support for our moms. And I think that their funding is ending, and they were our one referral for an IOP for our moms that really had a huge impact. And I would say we have about 4 or 5 women right now that program is ending, and they're sort of graduating out of that, and they're in real crisis. So that's another programming thing that we could look at that was very impactful.
Thank you. Dr. Costello, I appreciate your being here and sharing your wisdom and experience with us. I know you have to pop off right now, but Councillor Asabi George, I know this seems like we're just scraping the surface in this hearing, and we're not finished yet, but there may be potential here to have a working group going forward. So I think we have a lot more to hammer out in terms of identifying practical solutions. Thank you, Dr. Costello.
Thank you so much for having me. My pleasure. My honor.
And just to go to my other colleagues, Councillor Flynn, are you still with us? And Councillor Flaherty has joined us. Councillor Mejia, you're here. Have you any questions?
Yes, I do. Just a few. And thank you all for all your hard work. It's greatly appreciated. If you all wouldn't mind just talking to me a little bit about some of your, some of your approaches and support for women who are immigrants or who don't speak the language. Kind of what are some of the things what kind of supports do you foresee needing more of, and kind of what if you could just kind of help us get a better handle on some of the folks who English may not be their first language. If you have had any data or anything that you can share with us around that.
I can.
All right, Steph, you go.
Oh, okay. I don't have a number in front of me, but I can look back to you on that. We do have, I think that more than half of our staff speak a language other than English. So having staff who both look like and represent the population that we serve. We, again, have no conditions to enter shelter by sobriety, immigration status. We don't explicitly ask about that. We can deduce that by people who don't submit a social security number. And so our biggest challenge is working to help them find housing. So we don't have that as a precondition, but you cannot get a subsidy, a federal subsidy if you do not have an eligible immigration status. You can apply for state-funded public housing, but the wait for that is very, very, very long. And so people often don't have great options. We do have other housing programs that put people in market rate units, and we can support people financially that way, but working, trying to be creative to help people maximize their employment through other means is our approach. So our best thing is that we're trying to be creative. It is hard. We implemented a lot of kind of safety protocols and messaging during the Trump administration to help people make sure they felt safe in our facilities, and had kind of protocols at the front door. Members from ICE or Homeland Security were to show up in our shelters. So we're doing lots of work, but much more support is needed because some of the options are just not available that we can help other individuals with.
Thank you for that. And can you talk to us a little bit about just the overall stigma and kind of the work that is needed to have some of the additional, the family members support the moms who are going through this? Do you have that sort of type of communication with the families, or are you able to connect with some of the families to help support the women? I don't know if that makes sense.
Is that still directed to me?
Well, whoever can answer the question. So I guess what I'm trying to get at is, like, oftentimes what I have seen is that when women who are experiencing issues with recovery and are also parenting, that there is a level of stigma that is associated. So oftentimes the families are not all in, right? And so there is that additional barrier, right? So I'm just curious who or what, or if any of your programming will help to support kind of the reunification of some of the families to kind of help wrap their arms around the individual as well. Or maybe this is probably a different hearing, I don't know, but I just figured I asked while I'm here.
Yeah, Counselor, I'm happy to answer that as it relates to our substance treatment programs, particularly Entre Familia in Mattapan, which is a program that is specifically for women who need treatment and have the opportunity to bring be reunified with their children at the program, but also serve pregnant and postpartum women within the program. And you don't have to wait just for this particular program 6 months to get in either. We take people right after they're medically cleared, so women can start that process and work with DCF on reunification if that's what is required, which most oftentimes it is. And there is a lot of education within that program around the family piece, because certainly we know that after the program, people go back to their communities and their homes with others. So there is a lot of education and support for that. It's also a bilingual, bicultural program. It is a Spanish speaking program as well as English speaking. And so, we have the opportunity for that interaction with family members as well, where English is not their first language.
Thank you for that. And then for my last question, Councilor Breeden, I'm just also curious around HIV and AIDS and infection rates. Just curious about if there are anything that you all are doing around just to kind of address that, if that is an issue that comes up during your intake, or are there any additional support services around STIs and HIV and AIDS.
I can speak from.
Go ahead.
There's just from the small piece that we're doing, we do screen for that and ask that in kind of various intakes, and don't expect that a client might disclose that upon our first meeting. Having HIV is a kind of priority population in the city for housing resources. So there are multiple programs that individuals do that. So we have a whole staff who's kind of multiple staff are actually dedicated to helping individuals in those get into housing, which doesn't solve all of their issues, but does help to address their homelessness and get them connected to other services. And we have been working at the Health Commission and could loop back to you on more specifics on that our Infectious Disease Bureau is leading on coordinating the response to the rise in HIV infection rates, particularly in the area where our services are located.
Thank you. Thank you for that. I don't have any further questions, but I just wanted to let you all know that whatever you need from our office, we're here to support in any kind of way that we can. It's budget season, so we need those dollars to do all of this great work. So make sure that you all articulate what those needs are, which you have already done so, but just know that you have a partner in me, and thank you so much for all your hard work. It's greatly appreciated.
Thank you, Councillor Mejia. Pam?
Yeah, I want to bring up something. I mean, I'm hearing all this wonderful resources on shelters, etc., medical care. What about the development of workforce? Women, one way to help us move forward is to provide women with some self-esteem, some kind of way to come forward where they can start looking at to make a living. We work with women that are coming, like I said, from the shelters, off the streets, from being trafficked, that have no means of knowing, afraid to work. What about the women that this could be a means of a way, re-entering, doing their quarry work, having them understand that they have a purpose. Once they go through your programs, job training is just as important to me for them to look at themselves as helpful, useful parents, as women, as being a part of this society where they have a story to share with other women that are sitting in the situations that they've been in. We have seen so many success stories here with women that are doing well, that are working in hospitals and psychiatric departments, that have moved forward, that have graduated from college, who have graduated on scholarships provided that we try to help with, moving forward to bring back what they've been through to share with the women in our program. I mean, everything that we're talking about is important, but my aspect is, what about the women in need after they leave these programs? The daycare, we have women that can't come because there's not enough daycare for them to come to the program. They're only here a couple of hours, but what they get is a lifetime of support, understanding, love, and respect. We never turn you away, no matter if you relapse times. Our doors will always be open to you to come back, to grow, to pick up from where you left off at. I'm worried about the mental health of women. We also provide some mental health support, not at the level that you're doing it right now, but we provide that so you'll be able to go to work, to share your stories with other women that look like you, that sound like you, that you're not the only one. And educational programs. I'm so tired, and what we always offer women historically, working with children, cooking some food, or delivering something. Why can't we provide more programs for women that are interested to go to the next level of education? Why do they always have to be somewhere where it's not even a trade, ending up in a Dunkin' Donuts, ending up being in a stock room? And there's so much more talent if we take a few minutes to analyze, to talk to them and understand who they are. And groups, to provide more groups around parenting. Even like at our program, the funding, the money to bring in groups, we're a nonprofit. It's not always the easiest, and I sometimes feel that we are kind of overlooked with the services we provide. And I'm just curious, I don't hear anything about workforce development out here. And to me, that's one of the major fields. If we're going to walk hand in hand in recovery, then it has to be a next step, and I haven't heard that. Thank you.
Thank you, Pam, for raising those very, very important issues. I agree with you. Workforce development is hugely important. And educational programs, not to see an entry-level job in Dunkin' Donuts or somewhere. That shouldn't be where we're shooting for. We should be aiming higher and trying to recognize the resilience, intelligence, and incredible potential that these women have. So thank you for raising that. I think that may be a conversation that we need to expand later in another venue. Councillor Sabi George, had you further questions or?
But it seems that Councillor Mejia may have a follow-up question.
Councillor Mejia, do you have a follow-up question?
Yes, I do. Thank you. And I'm so glad that Pam brought that into this space because I worked at Goodwill as a job specialist, and I got like a 30,000 page curriculum to get women back into the workforce, and I threw it away and I said, no, I want to do my own, and I focused on helping women identify viable careers. So it's not just about getting women work and then having them work at Target. And, it's really about, if we're really serious about self-sufficiency, we have to really be able to think about workforce development, because when you have a sense of self, then you have a sense of purpose, right? And I think that is all part of that transition plan and making sure that they're able to fulfill that. And then the other piece that I want to bring, now that Pam has opened up the Pandora's box into this conversation, is that I worked at Project Hope as I was volunteering. I didn't work there, but I was doing training with women who were transitioning out of the shelter into their own homes. And I think that it's really important for us to also think about how, when Pam talks about self-esteem, it's also looking at self-sufficiency and making sure that when they get back into relationships, they're not getting into relationships that will also put their housing at risk. So there needs to be a whole comprehensive conversation around what these transition plans look like, and that we're really tapping into the why that oftentimes the situations that we find ourselves in. And I think that the workforce development piece is definitely crucial because then that gives you a sense of self, and stability is key. And then the other piece of it is making sure that when women are transitioning into their own homes, which is the ultimate goal, that they can keep it, right? And sometimes it's the relationships that we get into with our partners that put our livelihoods and our homes at risk. And I think that is also should be included in some of the conversations moving forward in terms of supporting the women as well.
Thank you, Councillor Mejia. I think the one thing that strikes me from this conversation is that I think Kelly raised the issue about that this is not an acute illness. This is a chronic health condition that has legs, that keeps it going over many years, and that so much of our systems is really geared up for the more acute level. I'm just thinking in terms of how long do we need to keep, if we had the resources. I think the reason we cut off services is because we don't have the resources to go longer. It's not a sprint, it's a marathon. But how long do you foresee the services should continue for? I think that was Kelly might have an idea, or any of you could answer that question.
Yeah, well, I'll jump in on that a little bit. Just in my small piece of it is having the medical side to refocus what postpartum care looks like, and recovery and postpartum care to be. We've stretched it to continue for a full year. I think a lot of recovery programs will say that first year is gives you a solid ground, but that certainly is not where that ends. I think that if we can focus on it being a sustainable support, but graduated in a sense that the resources can taper sort of over time, because we certainly wouldn't be able to have the resources and the funding to provide that intense recovery support during that first year for the next 15 years, right? But something that allows the women to build their own self-esteem, their own training, and bring life and sustainability to that recovery model or program. So my whole dream is that we would have a physical space, maybe where we could have multiple agencies kind of working in a physical space that could in and of itself be a workplace opportunity for the women who are healing and growing and in recovery, who can continue to work there and take that on to continue that sustainability. And I think it's so key what everyone is tapping into is that what Pam was saying, what Councilman Mejia was saying, is that self reliance and that self-esteem in seeing yourself as being an agent for change and being able to do that for yourself and for your family is what sustains recovery.
Thank you.
I just want to add, I think we all know like relapse is part of recovery. So these things happen. For example, like with Project Place, for at least for the crew department, so we take you from the jail facilities, you release, and we work with you for 2 years, but we say to you, we're always here for you. Like you can call us no matter what, because I mean, you could be at the top of a mountain one day and be rock bottom the next, and we want to be there to support you. So it's like, I think in terms of asking how long these services need to be continuing, I think it's always, just because I feel like there's always going to be somebody who's at that level of need. But it's not to say, obviously, if we're doing our jobs right, that level of need should diminish and they should be less reliant and less reliant and less reliant. But I think just the comfort and support of knowing that somebody with the right level head is there for you helps you continue to sustain. So it's like, even if like some models, you'll reach out to somebody every week, twice a week. And then, you know, once they start sustaining, you reach out to them once a month. And then they start sustaining, you reach out to them every 6 months. And then it's like really just every year just to check in, say, hey, did you not call us? And you really need us? Like, what's going on? Do you need somebody? Because I think everybody needs somebody. So I think in terms of when we're thinking about like continuing that care, the wraparound of our family supports and the wraparound of keeping everybody involved also holds that person accountable a little more. But just going to reiterate back, I think it's vital to keep these types of services available, like at all times for people, because there is really no tell but inside forces could implement change in those people's lives where they might feel like they need it again.
Yeah. And unless you walk that in those shoes, you don't know. The vulnerability is intense, and things can come out of left field when you least expect them and knock you off your program and set you back.
Right.
Thank you.
May I say one more thing, please? And I'm done. I think when we all identify with our clients or our participants, that we've all suffered a trauma, and every woman at some place in our life, we've suffered a trauma. And I think when we can go back and remember those places in our life, and we're working with somebody, and we leave our doors open and don't have to share all of our stories, but let them know that I'm like you, I'm a human. I've been through this. I've been through a DV when I was younger, but I had mentors. I had people around me. I had women that took me by the hand and said, you know, you're much better than this. You can do a lot better than this. You need to go and work with somebody that can hold your hand and walk you through some things. I just think it's the time that we put in. And like Larissa was saying, we do retention every 6 months. We will call 1,000 people from 10 years ago just to say, hi, hey, remember me? What do you need? How you doing? We'll have people walk through the doors from 15 years ago that have just been released from being locked up for 10. and come back and start their life all over again. And I'm very grateful. We all might not be here, but there's somebody here that they remember. We have a staff member that's been here. She's been here 20 years. She knows everybody and still knows their name. Yeah. It's nice when you can walk in after 3 years and say, oh my God, look, here's Karen. And you remember her and she remembers you. It's a sense of community. It's a sense of feeling wanted and a sense of growth. And that's, I'm saying, but that's, I think, any of the service we provide, we need to humanize it a little bit more, be a little bit more warm, be a little bit more open, and be very honest that I've been in situations in my life too. People relate to you when you can relate to them. You know, I don't want them to think because I have a degree in this or a degree in that, I'm no better than you. This door could fall down on me tomorrow. Where am I going to be? On Mass Avenue, maybe? I don't know. So I'm just saying, here where we are, I know we give a place of hope. And if some kind of way we could join in and have young women contact and come and spend a little time, or we meet, it would just be wonderful to share all of these resources for a little bit more growth, to bring women into programs where we are willing and able and wanting to provide the services that might be helpful. That's my speech.
Thank you, Pam. Anissa?
Yeah, thank you again, Madam Chair, and again, thank you to our guests. And, you know, sort of this conversation, you know, and the hearing order was really to have a more formal conversation about some of the challenges that our women in particular need. And so I appreciate Pam sort of shifting the conversation towards some of the solutions, Kelly switching the conversation towards some of the solutions, especially thinking about this medical home model and creating that physical space for these things to happen. And I think it is, in the true sense of the word, creating a recovery center for that work to do. And then some of the conversation around the sprint versus the marathon. Certainly when we think about recovery and we talk about recovery, it is a marathon and it's a lifetime of work. But when we think about the day-to-day crisis, and we think about the impact of sexual violence and trauma, when we think about the impact of substance use disorder and a lack of access to, you know, intensive mental health services, all of the solutions there need to be thought of in a sprint mentality, because, you know, any one person today needs that help right now. So I am, you know, curious about some of anyone, whether it's Larissa, Jennifer, Jen, Pam, or Kelly, what your or Stephanie, what your thoughts are around some of the solutions that we need to be working towards. And, you know, our hope with this hearing is that it will inform some of the budget work that we're in the midst of on the City Council today.
Yeah, I think the Entre La Familia has an amazing opportunity for women to continue with their children, because I think childcare makes it really, really hard for women to stay in treatment, especially when, like Dr. Costello had said, when you burn those bridges and you burn those relationships and you have nobody to help you, you have no those supports. If you're going into treatment and you have a child, you're kind of risking them going into custody if they weren't already, and obviously those are not ideal situations. So I think that more, I don't have the answers necessarily, but I think maybe following in Entre La Familia's footsteps, or like researching other places of what that looks like for keeping women with their children while they're in care. Because I think that's definitely, like within history, something that really keeps them from being able to stay in that.
In those
as well as
programs,
housing in general. Oh, I'm sorry.
No, that's fine. In some of those programs, when we think about the intergenerational or moms and children in services and in programs together jointly, do we see higher rates of longer term recovery and success in those programs? Is there data that supports those efforts? You know, as a mom, I see sort of the benefit of doing that work together and doing it in, you know, not being separated from your child or your children. But are we seeing success?
Absolutely. I will speak to that. We are definitely seeing success with that. And you know, everybody's journey is their own. But I will say that the most direct line for our moms to relapse is loss of custody.
Right.
So keeping them unified and in treatment is really the key.
Right.
And Project Respect works very closely with New Day, with Entre Familia, with the Phoenix House, and we have two. And I think also the really important thing is to have sort of this web of interconnectedness. So we have two of our staff go every week to Entre Familia and do parenting work and recovery work. And we've just received a grant to expand that to doing that same sort of model to the Phoenix House, which is Entre Familia Latinos and Niños is primarily funded for Latinx families, and Phoenix House for Black women. And so in our efforts right now in our initiative to engage the Pregnant Women of Color initiative, which we're doing a lot of work on, we're really trying to make those connections to the treatment facility itself and to their medical care and their home life and their support network. We all know each other and there's sort of a connectedness to it. I think that's really important.
Thank you.
Another thing I feel like is a really big gap is funding. And I mean, that's everyone's struggle. Luckily, access to recovery has been really helpful in my experience with helping the women on my caseload be funded into their sober homes for at least 6 months. Fortunately for most, when they're starting looking for housing, 6 months in, they're usually successful. But when they have, like I have a client on my caseload who is DCF involved, and she had left a shelter about a year ago. So her housing situation is immensely burdening because she can't go into a shelter for about 2 years. She's just about to run out of her sober homing funding, so she just feels like everything's kind of falling back in on her. The relief 6 months ago was great, and now she just kind of feels like it's all like closing back in. So as we seek for more funding for her, again, she's working, but she's just trying to save for housing for DCF because she can't go shelter funding. So it's like these kind of all these puzzle pieces that she's trying to work against. So we're just trying to create and maintain partnerships that like help support her, get her parent aid through DCF. And kind of, I think one thing I was going to say is really just to tell women all of the options that they have. Because telling them, oh, like this will work for you, you might think that that's going to be their greatest option for you, but you don't know their whole entire life's experience. Again, telling them every single option they have allows them to kind of also have a choice. And I think that's helpful, but I will stop.
That's great. And, I think, when we think about this, the American recovery money that's coming in from the feds, that is, significant funds, but just over a few years, that we do need to be making investments with that money that are sustainable investments because it's not reoccurring money. So, this is a place where we can really double down, and if not with the amount of money coming in, triple down on some of those investments to make some sustainable and long-lasting changes to any individual's life, but in particular women, because we know the importance of women when we think about family, when we think about creating that lifelong opportunity for family, for mother, for child, and sort of the generational opportunities it creates. And I appreciate, Pam, too, with your talk about the workforce development piece and how, this teaching a woman, not fishing for her, but teaching her how to fish and creating those opportunities is that lifetime, that's creating the sustainability, not just for programs, but for that one individual. So that's so important. Thank you, everybody. I appreciate your thoughtfulness and your input and the work that you continue to do. Thank you, Madam Chair.
Thank you. Before we wind up, I wanted to read into the record a letter from Councillor Andrea Campbell. Dear Chairwoman Braden and colleagues of the Committee of Strong Women, Families and Communities, I regretfully cannot attend today's hearing on Docket 0234, order for a hearing to review the work women-specific outreach to health and healthcare programming to combat the opioid crisis. As the opioid crisis continues to devastate families and communities in Boston and across the Commonwealth, it is critical that we develop solutions to this issue that are centred around healing and both of the individuals and our communities. I will be ably represented by a member of my staff today at today's hearing and look forward to reviewing the committee's report and working with the committee on any recommended next steps. Sincerely, Andrea J. Campbell, Boston City Councillor, District 4. Does anyone have any closing remarks just to wind up? I think we've covered a lot of ground, and any other closing thoughts before we leave? Kelly?
I just want to say that this has been a particularly difficult month for our team with the recent loss of our very beloved patient, and just being part of this hearing today, knowing that there are such amazing, thoughtful, forward-thinking leaders taking a look at this population is really restorative. And I thank you very much for inviting us to be here and for doing the work that you're doing. So thank you.
Thank you.
I just want to share our appreciation of all the great work that you folks do every day. A lot of it is unseen and unrecognized, but it is incredibly important and essential work that you do. And we just share our appreciation of all of that and our gratitude.
Councillor Braden, could I say something?
Councillor Mejia, you have the floor.
Thank you, Madam Chair. So two things. I really do appreciate Councillor Asabi George's line of thinking around this whole idea of sustainability. I think, and it goes back to Larissa's point in terms of just always being there. I think that we have this assumption that once people go through the program and through our programs that they would be off and running and that's it. And I think that we do ourselves a disservice when we don't put in the long-term infrastructure for even checking in on people, even if it's every 6 months. You know, how are you? What's going on? Because 6 months later, there's going to be a whole new set of other issues that families, that moms are going to be containing with that they probably didn't identify when they first left. So I think that that constant check-in is really important, and I think that that is part of the long-term sustainability. I think that you should be someone who is getting support for life, literally, right? Because I just don't think that one and done is enough. And then I also think that there's an opportunity to really think about how we include some of our smaller businesses in this sort of work, right? Like literally it does take a village. There are a lot of barbershops and hair salons in the city of Boston that could provide makeovers, right? Or just like, because those things help boost your self-esteem, right? So I would really encourage us to really think like what does a community-wide wrap around your arms approach looks like when we're involving all of the different touch points, like the community health center that the mom goes to now. Like what are we arming those nurse practitioners with information on, like, so that when they are seeing a patient that they can be super mindful of, like, even the tone and language or even information that they're sharing. You know, when you go to the bodega at your local convenience store, what information is there that kind of helps reinforce your recovery and your journey, right? So I just think, you know, like, let's really figure out how we can look at this from all hands on deck, and that the whole entire community is supporting these women in their journeys. And so I just wanted to offer that as something to think about and do. We work with a lot of hair salons. So if there's anything that you all want to reach out to our office for, if there's women that want to go get their hair done and look beautiful, because that's part of the self-esteem. If they're going to go, there's Dress for Success, which is a nonprofit organization that helps women dress for success. So, you know, let's just think about, like, how we can all be more supportive. I always say that Boston is resource rich, but coordination poor. And we really need to start thinking strategically about how we can all work collaboratively across all of these different spaces to support women in this journey. So thank you. Thank
you, Councillor Mejia. I'm going to give the last word to Councillor Asabi George, if you'd like to make some closing remarks before we close.
No, thank you very much, Madam Chair, and I am just grateful for everyone's presence here today and commitment to continuing this work and doing it in partnership. I love the idea, Council Braden, of a working session of some sort going forward. I think that this will certainly be a topic that comes up in a few of our budget hearings over the next few weeks. So I look forward to continuing the advocacy for more of the sustainable work. And Pam, Kelly, Larissa, Jen, Stephanie, anyone who Astor agrees. Anyone who would like to inform some of those things that we need to be investing in, I'd love to hear. And you certainly find me offline. Thank you. Thank you, Madam Chair.
Thank you, everyone. Everyone. Yes, thank you.
Can I invite everybody? Can I have one thing? Project Place is having a gala on May the 13th. If you can go online, you do not have to make a donation. If you're interested in seeing what we do and the wonderful video of some of our successes, both men and women, please go to projectplace.org, go to the gala. Just register yourself. It's free. You do not have to donate. Everybody says, oh, donations. No. Just come and see what we do. That's all. I would love to see your faces there and see some of the success stories from the women and hear some of the things that happen here. Thank you.
Thank you, Pam. So with no further ado, I would like to adjourn this hearing. Thank you all for your participation. Thank you.
Thank you.
Bye, everyone. Thank you.